Hello, everyone. This PowerPoint extends our broader conversation related to healthcare delivery and policy. This PowerPoint will talk a little bit about public health initiatives and tasks, social determinants of health. It will also talk a little bit more about stakeholders in healthcare systems and provide some additional information on the type of healthcare organizations and services that are out there to address the public health need. As a reminder, when we're talking about public health activities, we're talking about a host of activities that is meant to improve overall public health. These activities can include preventing epidemics, monitoring environmental toxin, developing community-based initiatives, um, being involved in public awareness projects, education initiatives, as well as monitoring water, food, and sanitation. These are just some of the important tasks related to public health activities. We also know that the social determinants of health is also key when we're having the larger discussion of public health. Even though we may engage in public health projects and public health education initiatives, we also know that there is also a strong understanding that social determinants of health play a huge role in overall health outcomes. We know that families who make lower income tend to have poor health than those who have higher level incomes, even middle class incomes. We know that the quality of an education system will have direct impacts on a community's overall health status and health outcome. We also know a combination of income and education can also improve life expectancy outcomes. And we also know that social support, such as family and community-based support systems, can help serve as a protective factor for health outcomes as well. So those who have more social supports can mitigate stress, and this can improve their overall health outcome. We also know that having a strong or good social supports can help mitigate poor health outcomes because those support systems can help you related to improving your overall education related to illness. And social supports can also help you with basic necessities such as food, water, and shelter, but they also can help you with transportation to and from medical appointments. And all these type of activities serve as a protective buffer for poor health outcomes. And we also know that factors such as race, ethnicity, and zip code can go a long way in predicting someone's life expectancy and health outcomes. That shouldn't be the case, but we do know that social determinants of health will make a huge difference in terms of the overall public health of a population. Even though the public health initiatives are meant to improve overall health outcomes, they are not necessarily meant to improve the quality of our health system. There's still a lot more that our health systems themselves can do in terms of improvement to enhance overall public health. And their duties and responsibilities to the public is different than the initiatives and tasks of public health activities. So when we're talking about health system improvements and what are some of the things that specific health systems need to do to improve overall public health, three major areas we must consider in terms of overall improvement. Quality of the healthcare services being offered. And when we're talking about quality, we're talking about reduction in errors, healthcare related errors. We're also looking at improving overall patient experience in healthcare systems. We're wanting to look at access, how readily available are services for clients or patients when they're in need of services. Perhaps could insurance serve as a barrier to access for insurance? And when patients do have insurance, is it enough to cover the services needed, or will they receive additional bills in the mail because their insurance isn't covering all the services that are provided? Another area to look at when we're talking about access to health systems, we're also looking at where health systems are located. We do know that in some rural areas, health systems may not be as accessible to people who do not live close to transportation, or people who do not have a readily available public transportation system available to them. And then also in those rural areas, there are a lot of people who do not have money and do not have vehicles to be able to afford to drive back and forth, especially when the most comprehensive regional health system is located many, many miles away. And one of the areas that healthcare reform has been focusing on, specifically related to health system improvement, is decreasing healthcare costs. Yearly, our United States healthcare costs has risen to astronomical amounts, and healthcare reform, as of the last 8 years, has been focused on trying to reduce healthcare costs as well as improving quality and access of services. Again, one area that health systems can be very instrumental in, since they have daily contact with patients, is promoting healthy behaviors for patients that come into contact. So a lot of times they address the medical and the chronic illness needs of patients, but focusing so much on the disease and curing the problems oftentimes take away from the need to promote healthy behaviors and to help correct some of the unhealthy behaviors that resulted in a particular patient needing emergency or urgent care at that time. We also know that there are some additional areas of improvement for public health system. We know that we can enhance public health systems by making sure they're more effective through improving funding. This is specifically important when we're talking about public health systems such as health centers, federally funded health centers, nursing homes, when we're looking at VA hospitals and so forth. We also know that we still have a long way to go in terms of coordinating services between healthcare providers and institutions, being more accountable for the services that are provided, and having a stronger stake in the outcomes with patients once they're discharged or released from a health system. And we also know that we need to do a better job of being transparent in terms of medical care. Oftentimes, we don't allow medical information to be easily shared amongst institutions, and there's usually a process related to that. Sometimes this is by law through HIPAA, but sometimes it's even a barrier or a challenge for a patient to receive their own medical information. And this is important when it comes time to transfer care to another provider, or if that patient changes providers and wants to make sure that they share their medical history with that provider. So we need to do a better job of being transparent on the services that are provided to patients. And we also know that addressing inequalities in access and outcomes, this speaks directly to the social determinants of health. But we know that there are inequalities in healthcare outcomes related to race and income and education. And we again know that these inequalities have a direct bearing on the outcomes of patients' health procedures. When we're talking about improving the healthcare systems, who then would be responsible for doing that? Well, there are many stakeholders in the healthcare reform discussion. And when I'm talking about healthcare reform broadly, I'm talking about improving the system as a whole. But when we're talking about stakeholders, we're looking at people or groups with strong healthcare interests. And stakeholders usually have some power to shape healthcare or shape the direction of healthcare related to quality, cost, and access. And we also know that even though these stakeholders have a lot of power, or at least have the power to shape healthcare, they always don't agree in terms of their views related to healthcare, opinions about services, and then the values as well. So a lot of these stakeholders come from a place of power and authority, but they oftentimes do not agree in the direction that we must go in order to improve healthcare for all. When we're talking about stakeholders, we're looking at consumers, providers, other professionals, insurance companies, as well as public policymakers. Again, if you look at this list, you can see where some stakeholders may have more power than others. For example, providers in the healthcare systems may have a lot more influence and power over healthcare direction than the consumers, who are those who receive the healthcare services. We also know that insurance companies have a lot of power and influence, and may oftentimes have more authority than providers, because they dictate how much they're going to pay for services offered to that clinician. One of the biggest complaints from medical providers is that insurance companies are, in essence, in charge of the patient plan of care, because they are dictating what services they're going to pay for. And oftentimes these providers have to get authorization from these insurance companies in order to move forward with a plan. Sometimes they do not pay providers for screens that they feel are not important or necessary. And in that aspect, they're taking on, the insurance companies then find themselves in a role where they're taking more of a role of a provider, and that they're making clinical decisions that oftentimes override the provider's treatment plan, because they're the ones deciding whether they're going to pay for the service or not. And then oftentimes the provider then has to change their treatment plan to meet the expectation or the requirement of the insurance company in order to get paid. So again, if you look at this list and you think more critically about it, it's you can kind of see where each of these stakeholders can have power in their own right, but then some of these stakeholders may have more authority over the other in terms of ability to influence healthcare direction. Also, what can be clearly seen by looking at this list is that you can oftentimes see how the consumer and the provider may have different opinions in terms of the direction of healthcare. You may also see where the consumers of healthcare services and the providers may also differ in terms of values and opinions regarding healthcare services. Similarly, you can see where providers and insurance companies may also not agree with services provided. And then when you add the public policymaker, who should be more aligned in terms of values and opinions with consumers, that may not be as simple either. So consumers should, public policymakers should have a good idea of what their consumers are looking for. And ideally, they should be serving the needs of their consumers or their constituents. And so their views should not differ much from consumers, but we know that's not the case. Due to politics, power, authority, lobbyists, and other type of special interest groups, public policymakers sometimes find themselves in the middle of trying to align their values and opinions with consumers, but also trying to align their values and views with provider groups and insurance companies as well. So because a lot of these stakeholders have their own agenda, they have their own interests, it can turn healthcare reform activities into a very, very, very complicated ordeal. And it's oftentimes explains why, as a healthcare system, the United States is very slow in terms of their progress. Even now, our discussion related to healthcare reform is long time coming, and there are many other countries that are so much more advanced in terms of their healthcare system than where we are today. And a lot of that has to do with the competing agenda and the wielding of power from these stakeholders listed here. So now we're going to talk a little bit about medical care and treatment. When we're talking about medical care, we're talking about prevention. Prevention includes preventing a disease as well as maintaining good health to prevent ever acquiring a disease or a chronic illness. When we're talking about a health status of an individual, we need to look at what are some of the health policies that are in place to help keep that person or keep the population healthy. Then we have to look at what are the individual behaviors or population behaviors that may be impacting someone's health status. Of course, we need to look at the social determinants of health, because we know those things, social determinants of health, i.e. education, income, neighborhood that you live in, have a direct impact on your overall health outcomes, but also your life expectancy. Also things such as physical determinants, biology and genetics, and the availability of services. All these things are areas that you need to look at when you're looking at the health status of not just an individual, but also when you're looking at the health status of a population as well. When we're thinking about prevention levels, again, this is a review of something, an area that we've covered before when talking about public health. But when we're looking at prevention levels, you're looking at primary, secondary, and tertiary. Primary prevention level is reducing the probability of a disease. Secondary prevention levels is early detection and treatment. And tertiary level is preventing further damage of an existing disease. When we're talking about the levels of medical care, each of these areas that I'm going to further discuss will be targeting, will be offering intervention and prevention within these three prevention levels. So one area is acute care, which is considered short-term, intense medical care. It involves diagnosing of a disease as well as illness and injury. Another level of care is emergent or urgent care, which is immediate care for sudden illness or injury. Oftentimes, this care is triaged, meaning classified in terms of importance and who needs to be seen and in what time frame for what type of illness. One method that's used to do a triage is the Emergency Severity Index, the ESI. Again, the ESI is an index tool to help triage or classify patients in terms of how imminently they need to be seen by a medical staff person. So when you're looking at the Emergency Severity Index, it ranges from immediate to non-urgent. So someone who needs to be seen immediately based on this Emergency Severity Index will need to be seen in less than a minute. Someone who needs to be seen emergent will need to be seen within 1 to 14 minutes. Someone who's classified as being urgent will need to be seen within 15 to 60 minutes. Semi-urgent, 61 to 120 minutes, and non-urgent, 120 minutes up to 24 hours. Again, this is after presenting for immediate service needs. Oftentimes, in order for an Emergency Severity Index scale to be applied, someone would have to make some kind of emergency visit to an emergency room, and at that time they are categorized and decided when they need to be seen. As you may know, either from personal experiences or what you may have heard through family members or friends, these type of Emergency Severity Index scales are not always perfect. There have been people who did not score or scored in the lower levels, meaning non-urgent or semi-urgent care, when in essence they needed to be seen emergently or at least immediately. And there have been errors in this case, and unfortunately, people have had poor outcomes in visiting the emergency room because it was believed that their emergency needs were non-urgent or semi-urgent when in fact they were. So these are not perfect index scales by any means, but it is what we use in our emergency and urgent care services now to help try to classify and decide what patients need to be seen immediately and which ones can wait until the more emergent patients are seen. Another important development related to emergency care is the Emergency Medical Treatment and Labor Act of 1986. And basically, this act makes sure anyone who presents at an emergency room is stabilized and treated for service and care. So based under the Emergency Medical Treatment and Labor Act, all patients presenting for emergency care must be screened and evaluated. They also must be provided with stabilizing treatment and admitted to the hospital if it's necessary. An ability to pay or not pay for services should not be factored under this act. All emergency rooms in the United States abide by the Emergency Medical Treatment and Labor Act, and if they do not, they can be provided with stiff penalties and fines, and actually they open themselves up to litigation and lawsuits if they do not follow the Emergency Medical Treatment and Labor Act. Another level of care provided by healthcare systems is urgent care. Urgent care is illness, injury, condition, or a condition that's serious enough to seek immediate care, but not serious enough for emergency care. This includes ambulatory care, and this just refers to a person's ability to walk into a facility depending on their illness, or take their own self to the facility for services rather than needing an ambulance to take them in. Also, this type of care is offered by a physician practice or an urgent care center. Another level of services offered is pre-hospital care, and it is any care provided in the community or prior to a transport to a hospital. And this service includes evaluation and treatment. Some of the popular known pre-hospital care services include primary care services, specialty care services, as well as chronic care services. Again, these services are usually provided in the community. They usually occur in lieu of a transport to a hospital, or it can occur prior to needing to be transported to a hospital. And again, the primary focus on these services is to evaluate and provide treatment. Sometimes that treatment is enough to stabilize and maintain a patient, or sometimes it's decided at the evaluation point that a more higher level of care is needed, and then that person can be transferred via ambulance to a hospital. Tertiary care centers are hospitalizations for specialty care that need specialized equipment, specialized expertise, and involves complex therapeutic interventions such as bypass, newborn intensive care service, or perhaps admission into a burn unit. When we're thinking about quaternary care, that extends tertiary care to highly specialized and unusual medical cases. Another level of service intervention is subacute care, and this is inpatient care needed by patients after hospitalization or instead of hospitalization. In order to qualify for this level of care, you need to, or a patient needs to have at least one or more active condition, or a need for one or more complex treatment. Subacute care is usually delivered by intensively skilled nurses. A broad range of medical services can fall under subacute care, and it also includes some need for some type of rehabilitative or long-term residential services during the course of treatment. In addition, when you're talking about subacute days, you're looking at an inpatient stay of at least 10 days, 10 to 100 days in a specialty unit developed or created to specifically address that active condition or complex treatment need. We're also, Another level of care is also a rehabilitative care, and that is care that restores a person to their previous level of functioning. This is to help a person improve or regain activities of daily living. Long-term care, another service delivery level, and it's a range of services to support people's personal care needs on a long-term basis. A lot of these patients have lost a level of independence due to a medical condition or a chronic illness. Also, these patients need assistance with activities of daily living, or another term, instruments of daily living. Again, they just need overall help and support, either washing clothes, bathing, feeding themselves and eating, perhaps using a walker, wheelchair, and other type of devices. Another level of services is end-of-life care, and this is care focused on the last days and hours of someone's life. End-of-life care includes physical, mental, and emotional support, as well as social support to a patient. It's usually offered to people who have terminal illness or a condition that is advanced, progressing, and incurable. And it also includes palliative care, or what we also call comfort care, to treat end-of-life symptoms. And end-of-life care can also include hospice. And when somebody's designated for hospice, they usually have or expected to have 6 months or less to live. It's not uncommon for someone to be designated to hospice and live longer than 6 months, but at least from the doctor's evaluation and recommendation at that time, they must be certified, and their recommendation is that that person will not live 6 months or not. And if a patient lives longer than the 6 months, then just the doctor would have to just put in another certification stating that it's not believed that that patient will survive another 6 months. And so now we're going to talk a little bit about healthcare organizations specifically and what they look like. We talked earlier about the levels of care, but now you're going to get a better idea of who are the type of service providers that offer those levels of care specified earlier. Hospitals are a huge healthcare service delivery provider. There are community hospitals, rehabilitative hospitals, psychiatric hospitals, children-specific or pediatric hospitals, and other types of hospitals as well that falls under hospital providers. There are also physician organizations, and solo practices falls under physician organizations, single specialty group practice, multi-specialty group practices. Single specialty is just a group of providers that focus on a single specialty and provide that service, or provide a service to a specific population, where a multi-specialty group may be different physicians or providers that specialize in different areas that make up one particular group practice. They also have corporate medical practice, urgent care centers, community health centers, and ambulatory surgery centers. All falls under the category of physician organizations. You also have long-term care organizations, which include independent living facilities, assisted living facilities, and skilled nursing facilities. You also have rehabilitative organizations, which include inpatient rehab and outpatient rehab. And then there are also integrative delivery systems. These are newer healthcare organization models, in that there are a lot more developing to address the needs of patients across delivery systems. And these integrative delivery systems are meant to meet the gaps in services when care is not properly coordinated across a spectrum of healthcare services. So for instance, someone may go to a primary care doctor and needs to be admitted into a hospital. They're admitted and treated in the hospital for about a week, and then they're transferred to a rehab because it's believed that even though they do not need hospitalization, they're not quite ready to go home, and they need to work on activities of daily living before they are safe to go home and resume normal function. So an integrated delivery system may develop in that the primary care doctor is in a larger system with the hospital, so that doctor has admitting privileges in the system, in that health system, but also that health system has a collaborative relationship with a rehab facility, so their patients go directly to this rehab facility, and so forth. And then once the rehab facility, the patient is complete with the rehab, they may be transferred back to their primary care doctor for follow-up treatment. But integrative delivery systems can include emergency medical services, also home health services, hospice and palliative care, and pharmacies. That's another example of an integrative delivery system. In this situation, you may have emergency medical services who have a collaborative relationship to home health care services. So if, let's say, someone is admitted to the ER for heart failure and is stabilized, but they are referred to home health services to receive equipment like a pacemaker or whatever medical device that they deem is necessary to maintain this person until whatever the follow-up plan for that patient may be. Or an emergency medical services healthcare system may have a collaborative relationship with a hospice or palliative care, with the understanding that a lot of, or a significant amount of patients that they see will require some kind of comfort care or hospice care at some point in time. And again, it also makes sense that an integrative delivery system to also partner with a pharmacy to make sure that somebody who's in an emergency medical situation or who may need home health services and hospice have adequate access and connection to an appropriate pharmacy to make sure that their medicines are delivered and maintained in an appropriate way. So when we're talking about healthcare systems or healthcare organizations, we're talking about models of care and service delivery. These models, all of the models that I've just talked about, are meant to address some area of health need or health system improvement, either health access, quality, or cost. Healthcare organizations are independent, coordinated, or a continuum of health services. So when you're thinking about these health systems, you're looking at them, one, and you're evaluating or measuring the services that they provide as an independent, freestanding institution or practice or health system. But you also want to see how that particular health delivery organization or health delivery system, how they fit in terms of the larger health system. How are they coordinating their care throughout their hospital or throughout their institutions? How are they coordinating that care across the health service deliver continuum, whether it's how are they coordinating care with primary care doctors within their region, how are they coordinating care with pharmacies throughout the region, how are they coordinating care perhaps with home health agencies and so forth. So again, we're looking at them as freestanding institutions, and we're measuring their quality, cost, and access per institution, but we're also saying we're trying to measure how well they're doing about addressing public health needs as a continuum, and how are they collaborating and coordinating with other services to make sure that patient not only gets the best care while they are being treated within their facility, but to make sure once they're discharged, they continue to progress and have improved health outcomes when they're not within that particular facility. When we're talking about addressing quality of health, there are a couple of models that I won't go into here, but I will take the time to draw them to your attention. More information is available on these quality improvement models on Blackboard. The Institute of Medicine, Crossing the Quality Chasm, there's an article for anyone to read and look. It really identifies what are some of the things we need to do as a healthcare system to improve quality for patients. Also, the Institute for Healthcare Improvement, Triple AIM initiative specifically. Again, there is articles and web links on Blackboard, so you can access this. This is very important to look at how or what some of the models we are currently implementing to improve healthcare access to all, and specifically related to social determinants of health. Also, patient-centered medical homes and the Institute for Patient and Family-Centered Care. Those are also topics you may want to research on your own to better and educate yourself about what are some of the existing models of quality improvement. Under the Institute for Patient and Family-Centered Care, there's the Better Together Partnering with Families video, the individual and family engagement in the Medicaid population, and peer support. Again, these are brief videos that give you an idea of what are some of the cutting edge initiatives that different health systems are taking to improve overall outcomes in individual health, which is expected to improve overall public health. Thanks a lot for taking the time to listen to this PowerPoint presentation, and I hope you do take the time to look at Blackboard at the additional quality insurance models. Thank you.